A 8-month-old child. Presence to the emergency department. With respiratory distress. The child has a history of recent vomiting. And is suspected to have a full stomach. The decision is made to secure the airway. Due to worsening respiratory status. What are the risks associated with intubating a child with a full stomach?
The primary risk is aspiration of gastric contents, which can lead to acute lung injury, bronchospasm, pneumonitis, or acute respiratory distress syndrome, ARDS. Aspiration of acidic gastric fluid pH 2.5 is particularly harmful.
What strategies can be employed to minimize the risk of aspiration in this scenario?
Strategies include making the patient nil per os as soon as possible, using a rapid sequence intubation technique, applying low mask ventilation pressures, and considering the Sellick maneuver to reduce gastric insufflation.
Why might a nasogastric tube be considered before intubation? And what are its limitations?
A nasogastric tube may be considered to empty the stomach, but it may not be reliable, could facilitate reflux, and might complicate bag mask ventilation.
What is the role of cricoid pressure in this context, and why is it controversial?
Cricoid pressure is intended to prevent gastric contents from entering the airway during intubation. However, its effectiveness is controversial, and it should only be applied after the child is sedated and airway reflexes are lost.
What considerations should be taken into account when choosing an RSI technique for this child?
The decision should weigh the risk of hypoxemia against the risk of aspiration. A modified RSI with low mask ventilation pressures may be appropriate to minimize gastric insufflation.